Hello, this is Dr. James Camp from Lee College in Baytown, Texas, and this is my lecture on respiratory anatomy. Okay, so we have a lot of learning objectives to get through on this one, from the conducting and respiratory and upper and lower respiratory tracts to all of the respiratory structures that air passes through during inspiration and expiration, and the histological, both the gross anatomy and the histological anatomy of a lot of these things. Okay, so we're going to talk about gross anatomy and then the microanatomy of a lung lobule first. Okay, the first major feature you notice when you deal with gross anatomy of the respiratory system is that it's divided into an upper and a lower respiratory tract. These are somewhat conventional designations. They don't, air does not stop at the boundary of the upper and lower respiratory tracts or anything like that. But there are a couple of interesting differences. The lower respiratory tract is all a bunch of tubular organs that exist in a branching fashion, whereas the upper respiratory tract is more a series of open passageways that air simply passes through. There is one interesting mystery here in this, and that is where do you place the larynx? Okay. The nose, nasal cavity, pharynx, all very clearly part of the upper respiratory tract, all very easy to get to with a naked eye or a very simple scope, whereas the lower respiratory tract, the trachea, the bronchi, etc., need either a serious endoscope or usually more likely a chest x-ray or MRI to understand what's going on down there. But the larynx is sort of in between. You can get a view of it with a laryngoscope. You can, it is not a tubular organ. It is a big open space, kind of more like the pharynx in that regard. On the other hand, it is cartilage encased like the lower respiratory tract. So it's difficult to place. In my own personal view, I see the upper respiratory tract, the larynx, and the lower respiratory tract. Your book may place it with the lower, it may place it with the upper. Just to make things a little more confusing, the doctors who deal with upper respiratory infections are sometimes called ear, nose, throat doctors, ENTs. That would seem to leave the larynx out. But their specialty is called otolaryngology, which would seem to lump the larynx in with the upper respiratory tract. All right. You can also take the entire group of airways and split them functionally instead of splitting them anatomically. And functionally, you get a conducting zone and a respiratory zone. Okay, the conducting zone is all of the places that air travels through where the air is not affected by its travel through those. We're not absorbing oxygen, we're not contributing carbon dioxide to the air. The air simply is conducted through from point A to point B. At the very end of its travel, however, air enters a respiratory zone, which is the microscopic lobules of the lung, where here oxygen is capable of getting into the blood and CO2 is capable of getting into the air through the very thin walls of these respiratory membranes. And typically the respiratory zone is said to contain the respiratory bronchioles, the alveolar ducts, alveolar sacs, and alveoli, and the conducting zone is said to contain everything else. Okay. The upper respiratory tract can be split into a nasal cavity, which is shown in a sort of cyan color on this picture, and a pharynx behind the nasal cavity, which is split into nasopharynx, oropharynx, and laryngopharynx based on what those parts of the pharynx connect to on the forward side. The oropharynx connects to the oral cavity, the laryngopharynx connects to the larynx, the nasopharynx connects to the nose. The nasal cavity itself can then be split into a couple of areas. There is an olfactory region up here where the olfactory fibers, if you remember your olfactory foramina in the ethmoid bone, allow olfactory fibers to go from the brain down into the top of the nasal cavity. There is a nasal cavity proper, which this book calls the respiratory area. Okay, that's all of this. Notably marked by three large shell-shaped, spiral formations here called the nasal conchae. There's a superior, a middle, and an inferior one. They're named conchae because they look a little bit like the outer fold of a conch shell. But they're also sometimes referred to as turbinates, turbinate bones. Because they act as turbines. They cause the air passing through them to spin a little bit, and as that air spirals through, centrifugal force causes pollen and bacteria and such to spin outward and stick to the mucus lining the turbinate bone itself. And so the mucus lining there traps these foreign particles and then can be, those things can be metabolized away or sneezed away or any sort of thing like that. Okay. Finally, there is an area here, an entrance portion of the nose called the nasal vestibule. Now, a vestibule, if you've ever seen an old kind of ancient Roman building, they often had kind of a dome at the top here, and then they would have an area that sticks out on the front of the ancient Roman temple or gathering place or whatever this is. And this is called a vestibule. This word has come into more modern use. If you're a camping aficionado, you know that these days if you get a nice little dome tent like the one I recently bought my family in the hopes that they'd let us travel despite COVID-19. Doesn't look like that's going to happen. Oftentimes they will build these with an extra flap that comes further off the tent that you can take your boots off get your muddy boots off before you go into the tent. And that extra space is called a vestibule. Okay, I'm doing a horrible job of drawing today. And, you know, we've even seen this also in modern, you know, big box stores, Walmart, Target, whatever, often have an area here in the front of the store that you go to before you get into the store that has your little sliding glass doors, and as you kind of go in there, and maybe that's where the shopping carts are stored, maybe that's where the weekly sales flyers are being handed out, who knows what, but it's a place where you can stop and fold your umbrella if it's been raining outside, take your coat off if it's cold. And that, I think, is where the word vestibule came from, is your vestments are your coat, your cloak, your whatever, and that's the place where you would put them on as you leave and take them off as you show up. Okay, so we have these vestibules in real life. Well, we have a vestibule in the nose. There are actually 3 body cavities that have a vestibule. The nasal cavity has a nasal vestibule. The oral cavity has an oral vestibule there, and the female reproductive tract has a vaginal vestibule. So these are kind of places that you go to before you really enter the body for real. Okay, and the nasal vestibule is known for having what we call guard hairs. Those nose hairs that you may find fairly annoying when you reach up to rub your nose and there's hair there. Well, those are there to stop a gnat from flying into your nose, or to filter out large particles in the same way that the nasal conchae filter out smaller microscopic particles. These guard hairs filter out macroscopic particles. So really, you shouldn't be, you know, yanking your nose hair out if you're one of those people who has that nervous habit. You should be leaving them there to protect your nose from particulates. Okay, on all sides of the nasal cavity, we find heavy areas of bone. Okay, to lighten those bones a little bit, evolution has given us, for better or worse, these empty spaces in our bone called sinuses. These sinuses are surrounded, as with all such open to the outside world things, they're surrounded with a mucous membrane, and that mucous membrane produces a small amount of mucus. Well, that mucus would build up and just fill up our bones if it didn't have somewhere to go. So there are drain holes here that drain each of these sinuses into our nasal cavity so that any excess mucus can drain there and go away. Now, I can't give this lecture without my sinuses starting to throb in pain, because I've always been plagued by sinus infections myself. And that happens when very thick mucus builds up in these drain passageways, and at the same time, swollen membranes on either side get inflamed and swell up and close down those passages. So now the combination of thicker mucus, which might be an allergy-related thing, or it might be an infection-related thing, and inflamed membranes that trap that mucus up here cause painful accumulations of mucus in these areas, and that can cause things ranging from mild stuffy headedness to serious painful headaches, to a patient running a full-fledged fever because there's a full-blown bacterial infection starting off, because every time you breathe in, little bits of bacteria can get into this sinus, and if they can't drain out, then there's the possibility for them to grow without limit and overtake your body's ability to deal with them in those sinuses. Okay, so that handles the upper respiratory tract. Now we get to the larynx and the lower respiratory tract. The larynx itself I should pause for a moment and explain a little bit of Latin to you. This Y in X is pronounced like the English word inks. Okay, so a lot of people who grew up learning American English phonics want to pronounce this larynx, but that is not the proper medical pronunciation for it. The proper pronunciation is larynx. And anything having to do with the larynx is laryngo. Okay, so we might have laryngoscope being a device that sees into the larynx, or laryngitis is an inflammation of the larynx that can cause you to lose your voice. Anyway, that Y in X turns into a Y in G when we make it an adjective. Okay, the larynx is famous for a couple of things. It's got some of the only named cartilages in the body. It's got the only bone, the hyoid bone, the only bone outside the skeleton, unless you count the 3 middle ear bones on each side, but the only major bone outside the skeleton, which serves as an anchor for a great number of muscles, but also protects the entrance to the lower respiratory system from collapsing in any way. And in fact, if a patient has been strangled to death, it's almost impossible to do that without breaking the hyoid bone, and so that's one of the first things that medical examiners look at if they suspect strangulation was the hyoid bone broken. There is a thyroid cartilage here, not having anything to do with the thyroid gland, which is a butterfly-shaped gland down here a little bit. But the thyroid cartilage is responsible for the laryngeal prominence, also known as Adam's apple, because of a old legend, biblical mythology, that the first human, Adam, ate an apple that he was forbidden to eat, and that the idea is that that apple somehow got stuck in his throat forever, and so this little prominence is called Adam's apple. Anyway, men supposedly have a more prominent Adam's apple than women, but if you feel for it, you can find it on anybody. And then there is a cricoid cartilage, which is more prominent on the posterior side than the anterior side. There are also several of our famous anatomical O's: thyrohyoid, cricothyroid, cricotracheal, and there are muscles and membranes, ligaments in each of these places. The cricothyroid ligament is famous for being the site, the easiest place to stick a tracheostomy tube if something has permanently or semi-permanently lodged in the larynx, and you need to get air into the patient's lungs, and you can't clear the larynx for some reason. Maybe the larynx is collapsed or something. You can poke a hole in this spot here and thread a tracheostomy tube down into the trachea and feed air past whatever blockage there is there and get it into the patient's lungs. Okay, here on the posterior side, you can see that cricoid cartilage is much more prominent on the posterior side. The thyroid cartilage actually stops, is absent on the posterior side. And here we can see an extra piece of cartilage that we didn't see very well on the anterior side called the epiglottis. It is the only elastic cartilage in the body, and it is elastic because its job is to fold down and cover the opening of the lower respiratory tract, known as the glottis, from whenever you swallow food, because the larynx and the trachea sit just anterior to the esophagus. So as you swallow, food has to go over the respiratory tract in order to get to the digestive tract. So the epiglottis closes to keep you from literally inhaling your food, but then it has to spring up right away so that you can take another breath. The larynx also famously houses the vocal cords. There are vocal cords or vocal ligaments. The ones that I'm sketching in yellow here are called the true vocal cords. Those are the ones that actually vibrate to make sound. And the ones that I am sketching in blue here are called the false vocal cords or vestibular ligaments, and they do not make any sound. When you look at them with flesh on them, you can see that they also create a pair of folds, vocal folds and vestibular folds. The vocal folds are sort of a whitish color, whereas the vestibular folds, the vocal folds are a whitish color. They are the ones that vibrate. The vestibular folds are more of a reddish pink color that mixes with the rest of the flesh around there, and they are not vibratory. You can also see that each of these has an adducted and an abducted position. Those extra cartilages that we saw on the previous slide, such as the arytenoids, help control the positioning of the vocal cords. When the vocal cords are close together like this, air is forced between them and they vibrate and you make noise. When they're spread apart like this, air can travel through the glottis and not vibrate the vocal cords. Also, exactly how tight your vocal cords are being held at the moment determines the pitch of your voice. As I understand it, tighter vocal cords produce a higher pitch, so and longer, thicker vocal cords produce a lower pitch, which is why men tend to have lower voices, is because we at some point develop a wider, thicker larynx. Okay. The esophagus, the larynx connects to the trachea, okay, which is a long tube. It's about 2.5 centimeters wide, so about 1 inch wide. It is covered in these C-shaped. If you look at it from the top, they look like this. On the back side, they don't cover. There's a muscle, smooth muscle, where this touches the esophagus. So these are often called C-ring cartilages, but their official name is tracheal cartilages. At the very bottom of the trachea is a little cartilage that looks a little bit like underpants, known as the carina, and that sticks into the airway here on the inside to make sure that air traveling through the trachea is split evenly left and right. When it goes left or right, we get a pair of main bronchi. Those each split into lobar bronchi, and then those split further into segmental bronchi, and there are actually a certain number of bronchopulmonary segments that are defined by the branching of the segmental bronchi. But bronchi don't stop there. They continue branching after the segmental bronchi. There are estimated to be about 20 or more levels of bronchial branching in the bronchial tree. Okay. Eventually, however, the smaller bronchi get smaller and smaller and smaller. Eventually, they get to a point where the diameter is less than 1 millimeter. Okay, imagine how small that is. And at that point, they are bronchioles. There are two things that define a bronchiole. One is this idea that the diameter is less than 1 millimeter. The other is the idea that you notice these little plates of cartilage that decorate all of the bronchi are suddenly absent on the bronchioles. The bronchioles have no cartilage that keeps them open, and so they are capable of fully bronchoconstricting, like this little bronchiole there. A fully bronchoconstricted bronchiole has almost no space for air to travel through it, high resistance to flow. I've always wondered why your body wants to be able to do that, but never had an adequate explanation to that. But it does cause a lot of troubles. People with asthma often find that their bronchioles constrict too much at very inopportune times. Babies, infants to toddlers often have bronchiolitis, where the bronchioles become inflamed by a respiratory virus, and they find it very difficult to breathe without a device called a nebulizer that sprays moist air with a bronchodilator drug into their airways. If we look all the way down into the lungs, we find that they break into these structures called lobules. Okay, that's a lobule of the lung, and that zooms out to look like this if we zoom in tremendously. And if we look with a microscope, we find that each of these terminal bronchioles opens into a respiratory bronchiole, and that those further open into alveolar sacs and alveolar ducts, and of course the individual air sacs known as alveoli. Here are alveolar ducts and the alveoli. I like to compare this to an alveolar duct is like a neighborhood street, and the alveoli, the individual air sacs, are like the driveways coming off that street. Okay, there's not necessarily a fantastic division of what is alveoli and what is alveolar duct. And then occasionally you get kind of a cul-de-sac at the end of the street called an alveolar sac that comprises a number of alveoli that just open onto a central airspace. One interesting thing to note is that while we think of terminal bronchioles, we think terminal means the end, right? They're the end of the conducting space, but there is a step beyond a terminal bronchiole, and that is a respiratory bronchiole that goes down into one of these lung lobules. Okay, so if we look at the lungs themselves, neither of these is a front view of the lung, which is what I'm used to seeing, so this figure always takes me a little bit by surprise, but the top are side views of the lungs, and you can see that the right lung is divided into 3 lobes, superior, middle, and inferior. The left lung only has the superior and the inferior lobe. So if we put superior here, inferior here, and then middle is only seen on the right lung. That means there is also 1 fewer fissure between the lobes on the left lung. The left and right both have an oblique fissure. The right alone has a horizontal fissure. If we look from the inside, from a middle view of the lung, we see 2 additional features. There is an area called the root of the lung, which is this collection of 2 pulmonary veins, 1 pulmonary artery, and 1 main bronchus. Okay, that act like, you know, if you think of the lung as being a tree of bronchi, these 4 structures, pulmonary artery, 2 pulmonary veins, and 1 main bronchus, they act as the root of that lung tree. The other thing you see is that here there is a dimple in the lung around the root, where there is actually not any pleural membrane, and that area is known as the hilum of the lung. Just as we had seen a hilum in the lymph nodes and the spleen, there's one in the lung. Finally, if we zoom completely back out, we can see that the lung is surrounded by a membrane called the pleura. And there is both a parietal pleura, which literally sort of sticks to your ribs, and a visceral pleura, which sticks to the lung itself. That leaves a pleural cavity in between the 2 pleura, which is maintained at a slightly negative pressure compared to air pressure outside of you, so that the lungs will remain inflated. Okay, so this is a good place to pause this video and practice labeling your lungs and larynx and nasal cavity and such. And when you're done with that, we have this activity for you to practice tracing the airflow through all of these structures. Okay, so in our upper conducting zone, air enters through the external nares, also known as the nostrils. Okay, then flows into the vestibule, and then into the nasal cavity. It is filtered through one of three nasal conchae, and then flows into the interior or posterior nares, which are called the choana. From there, it passes into the pharynx. Nasopharynx, oropharynx, and my favorite word to say, laryngopharynx. Okay. Then we enter the lower conducting zone. We pass the epiglottis into the larynx. Here there are many cartilages, including the thyroid, cricoid, arytenoid, corniculate, and cuneiform. Okay, we pass the false vocal cords, known as the vestibular folds, then the true vocal cords, known as the vocal folds, into the trachea. We pass down the trachea and hit the carina, and then that splits us into the left and right primary bronchi. The bronchial tree is split into left and right main, then secondary, several lobar, and then tertiary, finally several segmental bronchi. And then there are many more levels beyond that. At the end of the conducting zone, we hit the terminal bronchioles. And then just as you get off, go through the terminal to get to the airplane, we go through the terminal bronchioles to get to the respiratory bronchioles. Then that takes us to alveolar ducts, possibly alveolar sacs, and then finally alveoli. Okay. Now we shift gears and talk about the histology of the airways. We're going to find that, as with all of our hollow organs, the histology of the airway is sorted into layers. The inner layer is always going to be the mucosa, which splits into a mucosal epithelium, which is most commonly a columnar epithelium, but gets thinner and thinner as we go deeper into the body. There will be a layer of mucus deep to that epithelium, and there will be a layer of connective tissue called the lamina propria deep to the epithelium. So the mucus is superficial to the epithelium. It's in toward the lumen here. The lamina propria is deep to the epithelium. It's further deep into the body. Then there is a submucosa layer, which is made of kind of loose connective tissue that provides a blood supply for all of this organ activity. And then there are functional layers. We might have one or more plates of cartilage. Okay, and we might have one or more bands of smooth muscle that help constrict the airways. Let's see how this looks. One specific example, the trachea. We see the mucosa here on the very inside. We see a little bit of submucosa around that. And then we see a very large amount of tracheal cartilage forming, again, as we said, one of these sort of C-shaped rings. And then we see a large collection of smooth muscle known as the trachealis muscle here on the posterior aspect of the trachea. As we get deeper into the epithelium, we get progressively thinner and thinner. So in the nasal cavity through the lobar bronchi, we have this pseudostratified columnar epithelium. As we get into smaller bronchi and large bronchioles, we have a simple columnar epithelium. Okay. Deeper still, in the terminal and respiratory bronchioles, we have simple cuboidal epithelium. They say this is ciliated, but I have not necessarily seen that to be true in looking at slides. That's often, you often do not see cilia at that level. And then in the alveolar ducts and alveoli, we have simple squamous epithelium that forms these little rectangular blocks. The one exception to this rule of everything being simple epithelium is in the oropharynx and laryngopharynx, we have a non-keratinized but stratified squamous epithelium. That is because we have to deal with what I call the tortilla chip problem. If you've ever swallowed a tortilla chip that you hadn't completely chewed before, you know that the little angles and bits on that will scrape their way down the back of your throat, maybe even all the way down your esophagus. And as they do, they can scrape away cell after cell after cell. The way our body deals with this is by having multiple layers of cells under those cells that can quickly replenish them and prevent your tortilla chip from actually destroying the tissue as it goes down. So any part of your airway that is also a food way, and that's your oropharynx and your laryngopharynx, has to be stratified squamous. We mentioned cilia. There are almost all of your airways down until you hit those respiratory bronchioles are ciliated, and the combination of mucus and cilia creates a phenomenon called the mucociliary escalator. And the idea of that is that when you inhale a bacterium, if it makes it all the way down to one of your bronchioles, it might eventually get stuck in your mucus. And as these cilia beat upward, they push that bacteria further and further out of your lungs up to your larynx, where you could then cough it up or swallow it or otherwise get rid of it. Okay. Last but not least, if we dive all the way deep into your lungs, we find that the alveolar sacs and the alveoli themselves have these simple squamous cells. Okay. These are known as alveolar type 1 cells, and their main job is to serve as respiratory membranes to allow oxygen from the air to slip through them into a pulmonary capillary and to allow CO2 from the blood to slip through those thin walls into the airways themselves. But there's also an alveolar type 2 cell, sometimes known as a dust cell because they initially looked like little bits of dust on the microscope slide. These secrete surfactant. Okay. All parts of your body that include cells, except for the dead cells of your skin, those cells have to be covered with a thin layer of water, at least what we call serous fluid. They have to be covered either with mucus or with water to keep them moist. Cells do not like drying out. Well, water has a property called surface tension, which means that if two droplets of water are relatively close to each other on a surface, they're going to be attracted to each other to try to minimize the surface area of water that's exposed to the air. That's why if you watch raindrops falling on a window, they keep coming together to make bigger and bigger raindrops. Well, the same thing would happen here. This water would be attracted to this water, and that would tend to collapse your lung. Okay. Infants born before about 30 weeks do not have enough surfactant in their lungs for them to be able to inflate their lungs properly. And that's one of the reasons why premature babies have a tough time surviving. Once your lungs start producing the surfactant, it breaks the surface tension and allows your lungs to inflate properly. Okay, so what we're going to see is that the trachea has pseudostratified columnar epithelium, C-ring cartilage all the way around it like this, and a smooth muscle layer on the posterior side. The bronchus has simple columnar epithelia, cartilage plates in certain places, and smooth muscle bands in other places. The bronchiole has more of a cuboidal epithelium, it has no cartilage, but it has smooth muscle bands aplenty, allowing it to do that full broncho constriction that we talked about earlier. And then the alveoli, what we see there is these little sticks of cells with an occasional blood capillary here or there. And that this forms pocket shapes that are those alveoli themselves. And these are all made out of simple squamous epithelial cells. Okay. So if we try to sum up these histological trends, the type of epithelium in the trachea and larger bronchi, we see pseudo-stratified columnar. Then we get simple columnar, most bronchioles, simple cuboidal, and in the alveoli, of course, simple squamous. And so the trend is thinner as you go deeper. The amount or shape of cartilage, we have C-rings here in the trachea and larger bronchi. We have irregular plates in the bronchi and larger bronchioles. We have none in the most bronchioles category, and of course none in the alveoli. So the cartilage trend is less cartilage as you go deeper. Okay, and then if we look at our smooth muscle, we see just the posterior band there. Then we see irregular bands here. And an almost complete circle of these here. So your trend is more smooth muscle as you go deeper. Okay, and that concludes our lecture on the anatomy and histology of the respiratory system. Hope you enjoyed it, hope you learned something. If you do, leave me a like, leave me a comment. Keep learning, keep studying, and I'll see you later for more exciting physiology of the respiratory system.